Welcome back, clinical problem solvers. We have a very special episode for you. And something is a little off today, which has me concerned. I don't see a spoon and an acai bowl in front of Ravi, which has me worried that we're going to fail today.
Consumed, Prof. Rez, don't worry, all good. In fact, you should be the opposite of concerned. I had enough time to finish it before today.
Jerome, do you want to unmute yourself? Jerome is going to be our epic guest presenter and say a few words to the audience.
Absolutely. Hello, everyone, again. Back for round two today. Jerome, PGY3 at MUSC and Rising Chief Resident, but very happy to present the case today and a proud CPS member.
And I had the great fortune of meeting Jerome in person at the Chief Resident Conference. And my face just shined when I saw him. I was so excited to see him. And who is teaching today? Who's doing the teaching points?
Hello, Prof. Rez. Hello, everyone. I'm doing the teaching points today. We'll be capturing all your poetry, hopefully.
Oh my gosh, we're so lucky. How are you?
Yes, I'm great and more great after meeting you guys now.
Fantastic. And who is going to be scribing today?
Hi, everyone. I'll be scribing today.
Zachariah, how are you?
I'm well, thanks. I just have to say that no pressure, Jerome, but you really set the bar very high yesterday. So excited for what we see today.
Oh my gosh, what happened yesterday, Robbie?
Prof. Rez, let's just say that there was a hidden gem, and the hidden gem was unsocked, leaving us all bamboozled.
What does unsocked mean?
I think that's the question, Prof. Rez.
This is what he does to me. I'm already confused.
So Jerome presented this case, and he told us that the final diagnosis for this older man with a history of multiple spinal surgeries, severe coronary artery disease, status post-CABG, who presented with chest pain and shortness of breath, the final diagnosis was a patient with a necrotic toe. And he took us on a journey that first told us that the patient was febrile, with no associated history of fever, and had a neutrophilic leukocytosis and a thrombocytosis. He then took us on a journey with scans and blood cultures and whatnot, only to tell us that the patient was a little shy and had never shown his toes to the provider. And it took a lot of provider and patient bonding for the patient to ultimately be like, hey, doc, I think you should see something. And on hospital day 1 billion, it felt, the necrotic toe revealed the clue to the ultimate case. I had lost about 3 liters of sweat, Prof. Rez, in yesterday's case, asking myself, where the heck is this infection? And it was unsocked at the end.
Unbelievable. What a case, Jerome. Oh my gosh.
I think he's literally bamboozled. I don't think you know what to say, huh, Prof. Rez? That's how I felt.
Well, I do know. I have to unsock myself because I had physical therapy and they make me walk on the floor where they walk with their shoes. So I need to unsock myself and then clean it with a sandy wipe. This is an important issue, Robbie. But why don't we get the whiteboard up, get the case going? Prof. Rez is going to come with some very clean feet.
All right, y'all, let's rock and roll. Apologies to the YouTube people. Timestamp 9:07.
Live. I don't apologize to them. I'm back in fighting mode. It's attack mode.
All right. All is well in the CPS learning space. All righty. So I'll go ahead and get us started. This is an 81-year-old gentleman that you're meeting today. He's coming from subacute rehab due to nursing facility concerns for progressive confusion and abnormal behavior. And if y'all want to reflect on briefly there, or I can get straight into the first aliquot, whatever you prefer.
I'll just kind of share. This is a very, very uncommon situation, and not a common situation. It's not uncommon to be dealing with this at all. And I think that it's really important to get collateral for sure. And I think the thing that we're going to try to establish is over what period of time did this person's behavior change? But more importantly, what their baseline behavior is. So I think we have to pay very close attention to what period of time, but also where did this person start? And I think only after we have a confident grasp of those two elements can we really make progress. So I'll be keeping an eye out for that. Hand the mic to you, Jerome, and then we'll actually hear more in depth from Prof. Rez.
Sounds good. The toes were actually okay. I'll say that to start off with. So the history is obtained from the nursing staff, and they basically said that at baseline the patient is conversational in full sentences. He has a background history of like mild cognitive impairment, but he is independent with most of his ADLs. He came to the facility about a week ago. He was in his usual state of health. Overnight, he developed delirium and was not able to really follow any commands, which is basically an acute change. He was not eating any food, drinking any water over the past 3 to 4 days prior to the acute change in his sensorium. But she did note that the patient had some fecal incontinence, which was more than usual. There were no focal deficits on the exam from the basically the provider that was rounding that day. The patient was not conversing as usual, and he was not on any narcotics, no fevers or chills or any other localizing symptoms based on the history that I was given. And I will say, in the emergency department where I met this patient, CT head was negative for acute ischemia. There was no subdural hematoma. Chest x-ray was clear. And then I'll stop there.
Wow, Jerome, what an expert presenter. Rabih, I think for this aliquot, what I'd like to do is talk about just cognitive impairment and then lead it up to the acute change for you then to layer on how you're processing that. And the reason I like to talk about cognitive impairment is because I was recently on service and I felt that for every patient, we were doing a MOCA, an MRI, and trying to understand where we stand for their progressive cognitive decline. Now, you know, Rabih taught us when we have an episode of syncope, right? We want to know what happened before the event, what happened during the event, and what happened after the event. When someone has any type of cognitive impairment, it's so crucial to really understand their baseline cognitive status. And Jerome, this is really tough to do because oftentimes people are sent to the emergency department in the middle of the night, or they don't have an advocate to really explain what their cognitive status has been over the last several months. In fact, we had a patient with mild cognitive impairment who underwent spinal surgery, and after the operation was delirious for like 2 weeks. And even though his son was his advocate, it still was difficult to truly understand what the cognitive status at baseline is. This is so important because the baseline cognitive status determines how concerned we should be for the confusion that the patient's presenting with. Because think about this, Rabih and I discussed the case of a patient with severe lung disease who had a PE and developed respiratory distress. When you take someone's reserve away, it's so much easier to cause an insult. Chronic kidney disease, much more vulnerable to AKI. Dementia, much more vulnerable to acute encephalopathy. So very briefly, when you have a patient and you suspect mild cognitive impairment, you'll do your best to get the history. But oftentimes it'll be difficult to get that history, but that would be the most important step you can take. And then after you get that history, it's going to be impossible to assess his baseline cognitive status during an episode of acute encephalopathy. Like, you got to solve that. But once you solve it, what you really are going to do is you're going to do a mini cog, which takes a second to do. Like, everyone should be able to say, hey, say 3 words, repeat it back to me, remember those 3 words, draw the clock. And then if that's positive, like they score less than 3 points or whatnot, then you go on to a full-blown MOCA. And if there's functional impairment, then you have dementia. So I think the juicy part is what we often see, which is the acute encephalopathy that Rabih will discuss. But the acute encephalopathy and how much we're concerned about it really depends on the baseline cognitive status, which is often difficult to know at time point 0.
That's just so eloquent, Prof. Raz. I completely agree with you. And I think that's still a question even right now, if we zoom in on the details of this case. For those of you who are in the clinical space and see a lot of patients, I think you'll extrapolate that when healthcare professionals apply the label of delirium, it often means that they're making the judgment that the patient's actually not rapidly progressive. So, when somebody sees, hey, I think they're delirious, they're often saying that the patient has a mild or moderate level of confusion, but they're not progressing to obtundation or coma. So I think you can make an inference, even though we haven't laid eyes on this patient on the physical exam yet, that his level of arousal is not significantly impaired. And I think the most astute clinicians take it a step further and apply the label of delirium strictly when one feature is present. When the patient's attention and focus oscillates, goes up and down, up and down, up and down. And that's the most specific and accurate label of the term that's being applied to this patient, delirium. And so if you take a moment to say, well, what does that fundamentally mean? Like, what does it mean for somebody to have an oscillating level of attention? And what's even more interesting is to ask the question, okay, when they're really, really bad, when their attention is poor, what helped them get better? How did they go from being really, really confused, not paying attention, and then all of a sudden in the morning when the sun is up and everything is fine, they're great again? And I think that tells you that delirium only really happens to people with vulnerable brains. And what's actually happening is that they have a very mild trigger for their vulnerable brain to not work. And that mild trigger often is a very small microscopic urinary tract infection, a small amount of a medication change, or even just the changes in the daylight pattern. So if you examine the last 100 people who people have diagnosed with delirium instead of encephalopathy, you will find the following. Their baseline mental status is often compromised, either in a way that healthcare professionals have recognized or in a way that they will recognize after this hospitalization. And the level of acute disease is often very small. If that were the opposite, and the patient has a level of acute disease that is severe, I guarantee you they're not oscillating. They're just going to get worse and worse and worse and worse. So if you take this patient who has 81, probably has some cognitive impairment, and you give him a necrotic toe like Jerome's patient yesterday, that's not going to show up as delirium. That's going to be progressive encephalopathy. So the question here is, how much trust do we put in to that label of delirium? And I encourage you, until you have seen the patient oscillate yourself, to not apply that label of delirium. However, I think there is reason to wonder about whether the patient is really just mild cognitive impairment or not. And for me, that's the fecal incontinence. And it's not just the fecal incontinence, which typically triggers folks to really worry about some serious things like cord compression, but it is how casually the fecal incontinence was kind of put to the side by presumably very experienced people. Like, oh, just stooling. What does that tell you? That tells you that these people aren't surprised that this person is stooling, losing their stool. And the fact that they're not surprised may mean that they should have been surprised, and maybe that is a disaster unfolding. But more often than not, it's because they're leading you something that actually is expected. And when it's expected, it usually means that the patient likely has severe constipation, and constipation correlates with cognition like no other. Unfortunately, all of us are headed that way, to a confused and constipated state. And so for me, Prof. Rez, I think the threads that we're getting are setting us up for a situation where the patient's cognitive impairment at baseline is probably underappreciated, and it seems like he's more confused at baseline than he might let on, based on the fact that the word delirium is applied, and based on the fact that fecal incontinence was not really responded to urgently. And so I'm inclined to go that way, but I completely agree with you that it's still a very open question. And for now, until we see the patient oscillate or we prove the patient's constipated, I would probably just keep a very, very broad lens. Sorry for that very dismal outlook on life, but Mike to you, Jerome.
Yeah, also optimistic, Robbie. I love that. Alrighty, so unfortunately, for you all, I actually was the resident that actually discharged this patient to rehab, so I know his baseline, and I'll be able to tell you that for the past 3 months, he's been in and out of the hospital. He has very severe peripheral arterial disease, and he was recently diagnosed with right fifth toe osteomyelitis. He had an amputation with intraoperative cultures at group Candida, albicans, and Pseudomonas aeruginosa. And he was discharged on cefepime and mycofungin to complete an empiric 6-week course of antimicrobial treatment. 1 month prior to me taking care of him and having this osteomyelitis diagnosis of his toe, he received several debridements prior to deciding to pursue amputation, and he developed DRESS syndrome after being treated with PO clindamycin and ciprofloxacin. He was treated by dermatology, and they were treating him with 60 milligrams of prednisone daily, and they were planning to down titrate on his taper for 10 milligrams every week. And I can go to the past medical history unless you all want to talk about that.
Proffers, I talk too much.
Jerome, why don't we get the past medical history too, and then we'll be able to lump everything together.
Absolutely. All righty. So first, past medical history, mild cognitive impairment. As I've already told you, there was concern in the outpatient setting, 3 months ago, that he was developing some vascular dementia. He's had several CT heads, as just so some chronic microvascular disease. They're concerned for some overlapping Alzheimer's disease because of family history. He also had hypertension, hyperlipidemia, as you're not surprised, type 2 diabetes with chronic diabetic neuropathy of bilateral lower extremities. He did have CKD with his most recent eGFR being in the 50s prior to these recurrent hospitalizations before I met him. He also had some reduced lower visual acuity, I should say, just from diabetic macular edema, and he was getting intravitreal injections from his ophthalmologist. Medication-wise, no surprise, losartan, amlodipine, aspirin, clopidogrel, Crestor, SGLT2, GLP-1, metformin. The only allergies that he had in his chart was clindamycin and ciprofloxacin, just because of the DRESS syndrome that he developed. No other drug allergies otherwise. Family history was pretty much unremarkable. And I'll stop there.
Yeah, that's super helpful and thorough, Jerome. And I think what this does is that it sort of paints a picture of the background. And the question becomes, how much is the background influencing our analysis of his current presentation? And the truth is, if you overemphasize the background and you arrive at the correct diagnosis, you'll be viewed as a genius. If you overemphasize the background and you arrive at the wrong diagnosis, you'll be viewed as an idiot. Not an idiot, but you'll be viewed as like biasing and anchoring and premature closing and all that stuff. Basically, Robbie, they're going to be confused, constipated, and idiots watching us on YouTube. But really what this does is it really paints the picture of a patient with severe atherosclerotic disease. And of course, they can have a component of vascular dementia, but I don't want to label him as dementia because so far he is independently active. But every disease is on a spectrum. So mild cognitive impairment seems very reasonable. And you have to realize, like, oftentimes patients who have dementia, they have multiple causes. Like there's a component of Alzheimer's, a component of vascular. It isn't always one or the other. And I think the osteomyelitis in the patient with diabetes is really not unexpected, especially if the A1C is elevated and the glucose isn't, greatly and tightly controlled, because patients are at risk of neuropathy, of abrasions, and their immune system is compromised. Therefore, they get a lot of superficial infections that eventually make their way in to the bone to give osteo. And I'll tell you, osteo of the toe is very difficult to eradicate with just antibiotics. In fact, it oftentimes becomes a question, should we amputate? And then, it's unclear and the patient's reluctant, and then we trial antibiotics, but oftentimes it does require source control. And here's the challenging part is every time you remove a little piece of tissue for a patient with diabetes, so first it's a toe, then it's the ankle, then it's the entire leg, the mortality just keeps increasing and increasing and increasing. They lose functional status. So, Robbie, I think what this does for me is basically says, is there a progression or a complication of that initial hospitalization? Like the osteo, we didn't capture the right organism, and therefore it's progressing. Is the patient back to remic and now confused? So I would definitely get blood cultures. Or is it something we did that has nothing to do with the underlying disease, a medication we introduced, something, for example? Or is it totally unrelated to this? And this just makes them even more vulnerable to another insult happening out there in the world. Let me pass the mic to you to just reflect on that and layer on, or maybe just crystallize, like, what are we trying to say in this aliquot?
I think you said it perfectly, Prophet. You're young and definitely not confused, but I won't comment on your bowel movements in public. Instead I'll hand the mic to Jerome.
Wonderful. So what I'll do before I actually give you this patient's vitals and his physical exam, I'll just give you the exam that I had when I discharged him before he went to the rehab facility. He was alert, oriented, could speak in full sentences. We were talking about the playoffs. He was very with it. He could move all of his extremities, but he was very deconditioned. And so he wanted to go to the rehab facility, obviously, to get more aggressive physical therapy, occupational therapy, etc. So that was his baseline. Now in the emergency department where I met him again, he is afebrile. His temperature is 98.1 degrees Fahrenheit. Blood pressure is 135/68. Heart rate of 84 and regular. Respiratory rate of 17. 98% on room air. And generally, whenever I'm seeing him, he's in no acute distress, but he appears uncomfortable. He is alert. He will look at me and he'll track me walking around the room. But I was not able to assess orientation because all he could say was, or he would just grunt and say, pretty much all he could do. He could follow one-step commands. He can put his thumbs up. He can stick his tongue out. There's clonus of the bilateral upper extremities. I wanted to tell him to assess for asterixis, but that was too complex of a description. So I tried to get him to mimic what I was doing, and it was just too complicated. But whenever I grabbed both of his bilateral upper extremities, if I push back just a little bit, there's a little bit of clonus. And the lower extremities, there was no clonus. I'm only confident enough to do patellar and Achilles reflexes, and those were actually normal. I could not assess his strength or his sensation due to his mental status, but he could move his extremities, all of his extremities against gravity. His MSK exam, it was normal bulk and tone in the bilateral upper and lower extremities. Head and neck exam, cranial nerves were essentially unremarkable. Pupils were equal and reactive. They were a little bit sluggish, but they were symmetric on both sides. Cardiopulmonary exam is unremarkable. His abdomen, it was soft, a little distended. There was no fluid wave, no evidence of any ascites. And then he just had some mild tenderness in the bilateral lower quadrants, no appreciable organomegaly. The skin exam, warm and well perfused, no pending edema. And his right lower extremity wound from the osteomyelitis from the toe that was amputated, the dressing was clean and intact. No other rashes that I could see anywhere else on his body. And I'll stop there.
Are you sure about that, Jerome? Did you look under the toes, under the socks?
Yes,
everywhere?
full skin exam. I flipped him over. There was
all
no pressure ulcer. There's nothing devious there.
Okay, sounds great. So, Professor, I think what's really, really interesting is I think the problem that we're solving has become so abundantly clear. And I will tell you, I think the easy way to label it is to say, oh, the patient has altered mental status. But I think that leaves a lot on the table. I think when most of the time when we say altered mental status, we say that the patient has a deficit in their arousal, right? That they're not waking up or they're sleepy or whatnot. So from that perspective, I encourage all of you to ask yourself, is this altered mental status? My answer would be no. And the reason that my answer would be no is Jerome was saying that the patient was wide awake and alert. And the patient was readily responding to Jerome when Jerome asked for a response. But what was abnormal wasn't so much that the patient wasn't vigilant while watching Jerome across the room. It's just how he was responding was weird and abnormal. So to call this altered mental status, I think, would be leaving on the table the evidence of focality here. We know that the patient does not have a deficit in all his cortical function. Otherwise, he would not be able to wake up and respond. And we know that he's hearing fine, but he's not producing right speech. And so the question is, wait, does he have a speech deficit? And I think that's really, really important to ask yourself. Because if you label this problem as actually aphasia, patient's wide awake, alert, and not conversing with us properly, that would be a very, very different problem to solve. And so that is an element. The other element is the fact that there's clonus. And I don't want to, I think that I honestly, I'd love to hear from Prof. Rez both what your reflex read of that exam was. A very powerful one. Patients tracking, alert, wide awake, but doesn't respond right. And also what you're making of the clonus.
And Robbie, that was just so elegant. Like to be able to distinguish encephalopathy from something that is much more specific than encephalopathy. I think your ability to do that really sets us up to solve the right problem, right? Like to really focus on what is it we're trying to solve here. And I'll be honest, when you see clonus, and it's interesting, it's clonus in the upper extremities, not the lower extremities, it's a marker of an upper motor neuron sign. And so you wonder, is something happening in the brain or the spinal cord? This would prompt me to do other neuro exams, which Jerome did, like assessing reflexes, checking for spasticity, just to see if there's any other markers of upper motor neuron sign. And what it does is now I'm thinking about the fecal incontinence that was like, not on our frame, but I think once you combine clonus, fecal incontinence, you have to do your best to address or to assess for strength. And here the patient's able to move against gravity, but just like when someone has a lot of pain or when someone is severely confused, it's very hard to assess their actual strength. And I just want to be very clear here. Robbie just said it, encephalopathy is not the problem that we're trying to solve. We're like true form of altered mental status. It's like more of a nuanced flavor of confusion. So you just wonder whether the strength is true motor weakness or is it an issue with the patient being able to comply. So Robbie, you asked for my reflex thoughts. My reflex thoughts is like, what can't I miss? And what I can't miss is something happening in the cord. So for a patient like this, I would like honestly, Jerome told us he was totally fine prior. And if his neuro exam was fine prior, I would have such a low threshold to MRI the brain and the spinal cord and err on the side of caution and let that study tell me, hey, Rez, you don't need to worry about something compressing or a mass, and maybe it ends up being an MRI negative upper motor neuron clinical syndrome. So that's sort of where I am. Like we're going to do the whole MIST workup, and I would add to it like some very good imaging, and then we'll look at the labs, get blood cultures. I think it can we can go any way with this, Robbie, in terms of the final diagnosis. Any thoughts on that, my friend?
Nada. I love it.
All right. I see you smiling, Robbie. So I'll present some labs now. On his CBC, his hemoglobin was 10, which is near his baseline. His white count is 11. It is neutrophil predominant, but there is 7.1% eosinophils, which is elevated. His platelet count is 260, which is near his baseline. On his metabolic panel, his creatinine is 4.06. His baseline creatinine 1 week ago, whenever I saw him, was 1.2. BUN of 49. His baseline was 21. He had a normal sodium, normal potassium. His bicarb was 13, anion gap of 15. His LFTs, his total billy was 3, mostly indirect. LFTs were actually fine. His alk phos was 120, upper limit of normal being 85, and his albumin was 3. His VBG was 7.26, PCO2 of 38, lactate was normal, beta hydroxybutyrate was 2.76, mildly elevated. I'll go ahead and tell you now, the blood cultures were negative, RVP was negative, urine cultures were negative, and I'll go ahead and give the urinalysis now. His urine protein to creatinine ratio was 32.2 grams, which is nephrotic range to say the least. Urine sodium was 95. We were able to get an ultrasound. I just put one and put on his bladder. His bladder was actually decompressed. We got a formal renal ultrasound that didn't show any hydronephrosis, normal sized kidneys for his age. His urinalysis also showed 5 to 10% eosinophils per high powered field. There was no casts that were there, and white blood cells were about 4 to 10 per high powered field. And I will stop there.
So Jerome, that's super helpful. And maybe what I'll do is I'll just tackle the CBC and leave the rest for Rabih to analyze. And for me, like what the CBC does is one important thing. Usually when people are septic or have an infection that has worsened, they become eosinopenic. Their basic eosinophil counts are 0 because you get endogenous cortisol when you're stressed. And the only infections that can cause eosinophilia or are more likely to is if you have a fungal or parasitic infection and some atypical bacteria. But like this 710 or whatever, 750 eosinophils sort of pushes us away from your common acute bacterial infections, unless someone had concomitant adrenal insufficiency. The hemoglobin of 10 is not surprising at all. Like this guy has chronic inflammation, and probably if we got iron studies would have a high ferritin. He is 81, and his creatinine may not be a great marker of his kidney function, so he also may have low epogen as another contributor to his anemia. And yeah, I'll leave it at that and just pass the mic to Rabih to tackle the rest.
Yeah, Prof. Rez, I think the renal panel is interesting because the bicarb is surprisingly low. And we learned that there's a little bit of an anion gap, but not too much. And I think the anion gap is accounted for by the beta hydroxybutyrate. And the non-gap component in the absence of diarrhea is probably the kidney dysfunction itself. And it's interesting because we have beta hydroxybutyrate without hyperglycemia. And so I think that invokes the possibility of euglycemic DKA in a patient who is on an SGLT2 inhibitor. Though when somebody is ill and confused, the amount that they're eating probably contributes a little bit to their ketosis. And I think the question is that sufficient as a trigger for his altered mental status? And I think that the answer to that would probably be yes, if he had garden variety confusion and reduction in arousal. But I don't think I've ever seen euglycemic DKA or starvation ketosis cause somebody to not be able to talk properly and stutter. So, yeah. So I think my analysis of the chemistry panels, I think the most remarkable abnormalities is kidney dysfunction. It is profound now. Before it was mild, and now it's extreme, and everything else is notable, but probably will wash away with some fluids and some nutritional support. And so I think the space that we're analyzing, I'd imagine now, is how the brain is impacted by the kidney. And I think the most common way that the brain and the kidney are impacted simultaneously is that there's something wrong in the blood, meaning there's an infection, sepsis, medication effect, so on and so forth. And something dissolved in the blood reacts with the kidney and reacts with the brain. But it's not uncommon for us to see altered mental status develop in the context of a kidney dysfunction owing to uremia, which is not a sufficient level of kidney dysfunction to invoke here. But the accumulation of medications in patients with kidney disease is so common. 3 days ago, I had a patient who came in confused, and his diagnosis was gabapentin-induced encephalopathy, not because of overdose that he did, but because of overdose that happened because his kidney function plummeted. So I think now we have to look back at the medications very closely and say, are any of these medications not fun to have when your kidney is dysfunctional? And if the answer is yes to those, the only way we'll be able to diagnose these things if we actively stop them and make sure that the patient is allowed to clear them. So yeah, I'd probably give this person fluids. reassess their bicarb and their beta hydroxybutyrate, and I think I would get on the phone with a pharmacist to ask about meds in the context of CKD. And today, my pharmacist is the one and only Prof. Rez. So I'll hand the mic back to you and see what you think about the meds.
That's so brilliant, because you know that patient I was telling you about with the cervical spinal surgery, and then he also had end-stage renal disease, was on dialysis, and was on a host of medications from duloxetine to gabapentin. And the moment we stopped those meds, the next day he was totally lucid. And like, even when I threw this stuff into open evidence and GPT, they're like, in someone with end-stage renal disease, confusion, like leading that DDX with meds is probably the way to go. And here's what's so interesting in the thought exercise I went through. I think we're all familiar with cefepime and cephalosporin-induced neurotoxicity, and it gives us a specific flavor to the neurotoxicity with the clonus, maybe the myoclonus, and like it has a specific illness script. And so then, you know, if we're being practical and this patient came to the ED, unless they got, you know, a physician like Rabih, they're probably going to get an MRI of the brain and spinal cord. But I was really trying to challenge myself, Rabih. If the illness script really matches, do we need to proceed with that? And I think the answer to that question really has to do with like this fecal incontinence. Is it new? Is it old? And if you don't know, then it's better safe than sorry. Because remember, with these studies, it's only not doing these studies is only high value care if you don't miss a life-threatening, you know, condition. But if it's even 1% of the time you get it, then you should do it. But I think the cefepime would be a really nice link to this presentation. And it goes back to what we said originally, Rabih, like you get a procedure, you come back worse. Is it progression of the underlying disease, or is it something that we may have done to you? So right now, and I'd love to hear from you, honestly, because I think you have a great illness script. Are you doing any imaging, or, you know, we have the CT scan. Are you doing any additional imaging, or do you need more history to then make that decision? Or is this slam dunk cefepime neurotoxicity for you?
Yeah, I think Prof. Rez, it's really interesting because I learned from Aaron the speech deficits that Jerome described are actually really, really characteristic of cefepime-induced neurotoxicity. We had a case together. I think I presented it to you. I can't remember if I did or not. Did I?
If you did, then my memory is really poor, because I don't remember that. Or I would have asked you, do you want an MRI?
Prof. Rez, we've been rescued by the one and only Dr. Jasdeep Bajwa, who said, yes, I did. I vividly remember this case, Prof. Rez. Of course, you never want to anchor here, and you want to make sure that knowledge doesn't disable you in real life and that you don't harm a patient because of something rare. Cefepime-induced neurotoxicity is not something we see rarely, as we see commonly. But I vividly remember this older gentleman who, just like Jerome, was a great functional status, came in and was just talking all weird. And it was so cool because Aaron was the consultant, and I haven't looked at it myself, but I remember that. So I don't know. I think what would happen, honestly, what would I do in real life? I would probably stop cefepime for sure. And then I would consult neurology to ask them, hey, I wouldn't be running towards imaging because of the knowledge about cefepime that you just outlined. And I would probably pass the tension on to the neurologist. And whenever I do that, just as an analogy, whenever I ask neurology if they want imaging or not, guess what their answer is? Yes, please go ahead and get it.
And please get the LP afterwards.
Yeah, exactly. So you're right. Now that I think it through, I think in real life, I would probably be like, oh, maybe we can get away without imaging, but I think it would probably happen at some point. Yeah.
I just love how we all have parallel experiences with this guy. Alrighty, so for the next aliquot, we got a non-con CT abdomen pelvis just because of the lower quadrant tenderness and the fecal incontinence that the nurse from this facility told me about. And it essentially showed no hydronephrosis again, but there was a stable 12 centimeter cyst of the right kidney. It was the same size and character as what we had on CT from 2021. It showed moderate stool burden in the sigmoid, no concern for stercal colitis. There were some gallstones, but no evidence of cholecystitis. EKG was obtained to show a stable right bundle branch block, some nonspecific T-wave abnormalities, and the routine EEG, once the patient came up to the floor with us, was negative. All right, and I can stop there, and then
all I'm inclined to say is I told you it was constipated. That's all I have to offer, Professor. What do you have to say?
Jerome, just quick question for you. This cefepime, is he still on it? Is it off? What's the status with that?
yes, he was on week 4 of 6.
Week 4
At the time that he presented. So yes, he was still on cefepime, and he was still on mycophenolate for the Canada albicans.
Man, you see that this is so the beauty of medicine, right? Like when you start reading more and more, you just gain a better grasp. Like to learn that pro from Aaron, and then for you to be able to apply it to this case, Robbie, is why we do what we do. I think after you said what you said, um, why we do what we do, after you said what you said, I would feel honestly like if this case, if I were the hospitalist and this case came through, knowing what you have armed us with, what Aaron has armed us with, I would just stop the cefepime and let's. Do you know, Robbie, like how quickly that should resolve? Because that's going to be an important part of how we react, afterwards.
I don't know, Professor. My guess would be days, probably not, but I don't know. I'd have to look it up.
Any other thoughts?
Nada.
Confused, constipated. We're
And
all
then
heading that way.
And we're hunting for a third C, Professor. That's the 3
Yeah,
C.
that's true.
Mike Pedro.
All right, so we'll move onward. Because of his impressive AKI, because he was volume down from the history that I got from the nurses, I gave him 2 liters of lactated ringer just because he was volume down. I did talk to nephrology, and once they looked through the labs and saw that his history of DRESS with all this and the peripheral eosinophilia on admission this time, they said, well, this could be AIN, but it just could be ischemic ATN just from hypovolemia. So they said, let's just go ahead and get a renal biopsy, which I'll give you the results of those now. It essentially said that the pathologist interprets the findings were non-specific, but it was suggestive of diabetic nephropathy that can be seen in the setting of hypertension and obesity as well. He had background tubular interstitial changes that were starting to actually improve because by this time we got the renal biopsy, he was on steroids. They actually started him on steroids for AIN. And I'll go ahead and reveal the final diagnosis just because you all nailed it. His I had to present this kind of in a different way because it would have been too clear, but his cefepime level was 45, and toxicity can be seen around 20. And so ultimately, with that background history, whenever I saw him again, that was leading on my differential. And so ultimately, whenever we saw that, it was like, well, all these things seem like very plausible diagnoses, but we ultimately held the cefepime. They put him on Zosyn. They volume resuscitated. His renal indices didn't really improve that much. His mentation didn't improve that much. They decided to move him to the ICU and to do dialysis to actually treat the cefepime toxicity because his neurodeficits were so profound. And within 2 days, he had 4.5 hour sessions of just renal clearance. He turned around back to baseline. And so he was back to his usual state of health right after.
Man, that is so fascinating, Jerome. So fascinating. Robbie, I was just thinking about like lithium toxicity. And what we know with lithium is that it actually invades the CNS. And despite the blood levels being low, that neurotoxicity can, linger. And so maybe with cefepime, it's different. Maybe it does affect it, but it doesn't stay there for a prolonged period like lithium does. And always remembering like dialysis is an option. You just have to know whether it can be dialyzed off or not. But remembering that in our treatment algorithm of, these toxicities.
Robert, as soon as you mentioned lithium, you reminded me of my favorite RLR teaching video that you made about lithium. It was Professor says, well, I don't know, 100, maybe close to 100, if not more than 100 teaching videos on RLR CP solvers, but hands down one of my absolute favorites. So if you're subscribed to RLR CP solvers, I think nothing will better explain what he just mentioned to you about sometimes the disconnect between what's happening in the brain, what's happening in the blood. I didn't even know, Jerome, honestly, that we had the test of cefepime levels. I thought it was a clinical diagnosis, so that's huge learning for me. And also, upon reflection, it was really interesting that my mind glossed over the nephrotic range proteinuria. And if I were an early learner, I'd be like, wait, how did Prof. Rez and Robbie just skip over the fact that this person has 32 grams of protein in their urine? And that's really just to make it explicit because the patient doesn't have full-fledged nephrotic syndrome. So in the absence of hypoalbuminemia and lower extremity edema, the vast majority of nephrotic range proteinuria is owing to diabetic nephropathy. And so in this patient with poorly controlled diabetes, we see this all the time, a lot of protein in the urine, but without evolution into the full-fledged syndrome. So just wanted to vocalize that in case that was a lingering question. But for me, I think my biggest take is I wish, Jerome, you would present every day, quite honestly. The deliberate decision to just stop at the chief concern before the HPI for us to like really dissect this space. And then how you painted the picture throughout is just absolutely awesome. Really, really appreciate every single case you're bringing to us. And another, I think, really, really important thing to know, it's not as common as the case you presented yesterday, but I think it's equally important to know. Any reflections that you want to emphasize, Jerome?
Yeah, I have a few. From this case alone, it was really interesting to me because his neuro exam was just so vastly different from what I just discharged him with. So I knew that that was a component of his presentation. And though I've heard numerous of the attendings that I've had, they said that they've seen cefepime toxicity at least once, but each of the presentations that they gave me were all pretty variable in terms of what deficits people presented with. But what was common amongst all of them was like the language deficit that was just so profound. And so that was something that once, they called me down to admit this patient again back to our team. That was just something that was just glaringly obvious. So I knew that that had to be a part, but there were still other, AKI, mental status workup changes that needed to be done overnight. And so ultimately, once I, staffed this with the overnight attending and everything, they said, well, this seems like this could absolutely be the case. Let's just go ahead and make sure we do our due diligence overnight. Make sure we grab all the appropriate workup to rule out all the other common things so that whenever the day team comes tomorrow, then, we'll be able to advance this care the way that we need to. And so ultimately that was pretty helpful, but those were pretty much the teaching points. And what you alluded to with the people who have a background history of mild cognitive impairment or dementia, their brains are very vulnerable just to any toxicities just from medication. So that's something that if you have a patient with a vulnerable brain and they're coming in with AKI or reduced renal function, you have to look at the med list and do it thoroughly, because that's you have to do your due diligence and make sure you rule out the most morbid diagnoses. But a lot of the times you'll be able to be able to make a lot of progress there. And so ultimately, another teaching point was just that cefepime is actually dialyzable. And so whenever I spoke to the nephrologist, they was like, usually we just hold it, but with someone with severe deficits, we'll actually move for dialysis. And so within 2 days, I mean, he was, going from grunting to actually talking to me again. And he actually remembered me from the last admission. And then we resumed conversation again too, because we weren't the greatest friends because he's a Celtic fan. So ultimately, that's the reflections I have.
The only reflection I have, Prof. Rez, is I know what he means by that he's a Celtics fan. Just FYI, because I now know basketball, Prof. Rez. But anyway, I talk too much. Mike, to you, Simi.
Thank you, Jerome, for bringing such an interesting case, and loved the discussion. It was really poetry, and I don't have much to add, but just a brief summary. So whenever we have patients with cognitive impairment, we should always check the baseline of these patients, and we can get this test, mini-cog test, to check for the cognition. And then we talked about the approach to delirium, that when a patient has oscillation in attention and focus, so we can think about delirium, and there can be any trigger for delirium, whether it be medication, infection like UTI, or sometimes just a change in the day timings. And then we discussed that when the patient has involvement of brain and kidney at the same time, we can think about something being wrong in the blood, whether it be infection or medication. And then it was cefepime-induced neurotoxicity, which can affect speech in patients. And we checked the cefepime blood level, which was elevated, and dialysis is something which can help to reverse the toxicity. But thank you, everyone, and thank you so much for such a wonderful case and amazing, amazing discussion.
So Robbie doesn't aspirate. Simi, that was phenomenal. I think what I loved most about that is that you highlighted the main teaching points, but anyone can read more detail from what you've typed up. And at this point of this game, everyone's so tired. So being brief, and now I'm doing exactly opposite of what you did by speaking a lot, and people just want to log off. But that was really, really, I think it takes masterclass to be able to synthesize it so compactly. So thank you for doing that. Now that Rabih has swallowed his food, maybe he can sign this out.
Prof. Rez, your words should always be the last words. What are the 2 or 3 words you want to give people farewell for?
Confused, constipated, and
Cefepime.
oh, confused, constipated, and cefepime. What a goodbye.